Hi everyone, welcome to one of our promo videos for the upcoming International Cardiogenic Shock Congress in Abu Dhabi. We're very delighted today to welcome Dr. Amanda Vest, a leading expert in advanced heart failure, cardiogenic shock, and metabolic health, as a distinguished faculty member of the first Congress, Cardiogenic Shock Congress. Dr. Vest is a section head of heart failure and transplantation at Cleveland Clinic, Ohio, within the Miller Family Heart Vascular and Thoracic Institute. She completed her cardiology and advanced heart failure training in Cleveland Clinic. Then she joined Tufts Medical Center, where she spent over a decade. She served there as a medical director of the transplant program and led the advanced heart failure program as well. During this time, she developed a nationally recognized nutrition heart failure research program focusing on the intersection of nutrition, metabolism, and cardiac cachexia. Then she returned to Cleveland Clinic in 2024. She's a co-author of the 2022 AHA-ACC HFSA guideline for the management of heart failure, among other publications. Her NIH-funded research focus on skeletal muscle wasting, metabolic dysfunction, and nutritional interventions in advanced heart failure. At the International Cardiogenic Shock Congress, Dr. Vest will address two critically important topics. The first one is cardiogenic shock in women. Do the same rules apply? And the other topic will be acute right ventricular failure, and we will discuss the medical management. Welcome, Dr. Vest.
Thank you for having me.
It's our pleasure. So you will be speaking about cardiogenic shock in women. What promoted the focus, and what key differences do you think clinicians should be more aware of in practice?
Yeah, thank you so much for the opportunity to speak on these topics. So, the interesting piece that has come through based upon several retrospective studies looking at women's specific differences and cardiogenic shock management and outcomes, and a little bit that we can now glean from sex-specific analyses of clinical trials, such as the Danger Shock trial program, have really all coalesced us in the same direction of realizing that outcomes for women are either similar to those of men or a little worse. In most programs, they've been seen to be a little bit worse. But interestingly, there's quite a message that comes through about underutilization of diagnostic modalities. So that includes right heart catheterization to define hemodynamics. It includes angiogram in appropriate cases, and lower utilization of the associated therapies. So lower use of temporary MCS devices in shock and of revascularization where indicated. And certainly the data would suggest so far that that is the piece that translates into those slightly worse outcomes, is the lesser diagnostic and then therapeutic interventions. And so that's a really important message, I think, for our community and those taking care of patients. There are also, of course, concerns around female-specific anatomy and whether some of our temporary MCS devices are well suited to the female body, especially the smaller vessels that they may be deployed through. And so these are the pieces that many people in the shock area have been kind of grappling with and trying to put together when we're making clinical guidance for management of patients.
That's great to know.
Yeah, fantastic. And then, Dr. Vest, do you think the current guidelines with all the updates that you mentioned, especially in the shock, right? We talked about cardiogenic shock, for risk stratification tools and all in the guidelines, adequately account for the sex-based differences, or there's a gap apparently, and how we can address that?
Yeah, this is a really interesting question. And I think there are little pieces that we need to do better. Like, for example, there have been some proposals about risk scores that take into account some of these women-specific differences that I think could be useful here. But overall, I think our guidelines and our movement in this field towards kind of protocolized shock team care is actually the right thing, regardless of one's sex, of other demographic characteristics, because it turns out that the more we can sort of stick to our protocols, and for example, place an early right heart catheter and define those hemodynamics, measure lactate early and at the right intervals, because that seems to be a little undermeasured in women as well. The more we can do those protocolized things, I think the better our outcomes will be across the board. So big picture, I think treating patients to a protocol is the right way to go, actually. And then there are other pieces that we still need to do in terms of innovation and developing devices in a way that we really serve all the patient population. This includes the pediatric population, patients with complex anatomy, especially of the peripheral vasculature. More innovation hoped for there, but we do know, I mentioned danger shock. So for example, in danger shock, again, we saw it was the recognition and timing of getting onto device that seemed to be the difference between sexes, not the efficacy of the device itself. The device, the microaxial flow pump, seemed to work as well in women as it did in men when it was placed in a timely manner.
Sounds good. So let's move to the second topic you were discussing in the Congress, which is acute right ventricular heart failure. What do you think about the principle that the clinician should keep them as an early priority once identified that the patient has an RV failure?
Yeah, I think it's so easy to overlook the RV, but it's important, as you know, to both properly assess it and think through what would optimize the RV when we're considering our medical management. So in my talk, I'm going to propose a framework, which is the framework that I've come to use and that I discuss with our fellows in terms of going through assessment of preload and vascular tone, then assessing and managing afterload in the RV, followed by thinking about the ventilator if present, because there can sometimes be ways that disadvantages or helps us with the RV. Then assessing and managing RV contractility, so not reaching straight for the inotropes as the first thing, thinking about the preload and afterload first, but coming around to managing contractility and remembering the importance of AV synchrony in terms of sometimes the rhythm can disadvantage us when managing the RV. So I'm calling this first aid for the right ventricle in the ICU, and we'll talk through those concepts and just a few management tips to help optimize patients with right heart failure.
Looking forward to that talk. So that takes us to the last question. How do you see meetings like the International Cardiogenic Shock Congress help raise awareness about the critical aspects of shock care globally?
I think it's so important. I'm so glad this is occurring because we're a growing and rapidly expanding field in terms of both the number of people involved in our multidisciplinary teams, but also the knowledge. It hasn't actually been that many years that we've had both this field of cardiac intensive care as a real clinical focus, and not that long that we've had some of these tools. Various temporary MCS devices are really still in evolution, and even ECMO that we've had for many years, the concepts around how we best manage and optimize with that tool are still evolving. So I think it's critically important when we're in this sort of nascent phase and really just getting into the era of having society statements and guidelines with so much research coming forward quite rapidly, that we have these forums to share knowledge, discuss, and sort of refine our understanding. And incredibly important that we do that everywhere. And so being able to visit the Middle East region and share region-specific knowledge and understand with the tools available what are the right pathways to care for patients with cardiogenic shock, I think is going to be highly impactful for the clinicians and also patients in the region. So really looking forward to it.
This is very promising. Thanks so much for your time today, and we look forward to see you in the Congress.
Can't wait. Thank you.
Thank you.